Good evening. Welcome to our second opioid town hall for Martin County. My name is Micah Robbins. I'm the Director of Special Projects with the Palm Beach County Behavioral Health Coalition and a member of the Martin County Coalition. Tonight we're going to be discussing the opioid crisis here in Martin County, its developments, its effects, with our panel tonight. Today is not only our town hall, but it's significant that it's International Overdose Awareness Day. It's a day that we remember those we've lost to this crisis and also support those that we love and care about in our community that struggle with this on a daily basis. So I thank everyone joining us here live tonight, and I thank everyone joining us out in Facebook land as well. So tonight we're going to do things in a pretty simple pattern. I have some questions for our panel. They'll be directed to each individual, and I'll introduce them shortly. And then you have the opportunity as well to ask questions via Facebook Live. So we'll try to include those as best we can and get everybody's thoughts on this issue together. So this evening we have a wonderful panel. Joining us from the Sheriff's Office, Martin County Sheriff's Office, John Budensink, Chief Budensink. From Tykes and Teens, representing our behavioral health, Dr. Aneshka Marshall. Dr. Jay Kuchera, an anesthesiologist with Resolute practice, as well as an expert in this field and has been a community member supporting this effort. Chris Camel, who is the Martin County Fire Rescue, who represents not only that department, but those that are generally first on the scene when dealing with overdose and other issues around this. And finally, Robin Tupper, one of our momvacates, our mom advocates, a hero in this community, and she also represents our Two Sons, a local nonprofit supporting those with children in active addiction and also those with parents of loss. And we are pleased to have everybody here again. These faces should look familiar, as most of them were with us last year. Now, first for the panel, and I'm going to start with our friends in fire rescue. This is an epidemic wrapped up in the pandemic. Last year, we were basically in the same place with our COVID-19 challenges in the community. But within that, we have seen an increase in opiate use, overdose, so the epidemic inside the pandemic continues to rage on. What are you seeing as far as changing trends in your field, in your experience? And then secondly, we're going to talk about your profession as a whole and how you're all doing and how we can be supportive. What are you seeing so far in the community this year?
Well, thus far, since from 2019 through 2020, there was about a 25% increase in overdoses related to opioids, 187 in 2020. Thus far this year, we're about sitting at 87 right now, all opioid overdoses for the year, and the fall is definitely heating up and getting worse and worse and worse. And it seems to work concurrently. The worse when COVID goes bad and everybody starts hibernating in their homes, the opioids seem to increase at that point.
Have you seen any change of usage pattern, age groups, different communities, or any sort of changes in any trends or patterns around usage?
If you look at our numbers, the pattern is really not there. It's everywhere. It's across every border, in every neighborhood, in every spot in Martin County. We see it everywhere.
Does that cut across all age groups as well?
You see a lot more 20s, 30s, but I see a lot more now here recently, 50s and 60s, having serious issues with opioids.
Are you seeing the synthetic, the fentanyls, carfentanyls, and the like, the synthetic analogs, are you seeing that more pervasive in other calls that you're responding to?
We're unable to differentiate, but we do know and we can tell that when people do overdose, it's way worse, and it takes a lot more Narcan to revive them than it used to. So we would postulate that, yeah, it's fentanyls and the synthetics.
And actually, this will lend nicely to Dr. Kuchera. You're treating a number of folks in both camps, if you will. There are those that are using opioids as a prescribed medication. That is a class of folks that are using these products. But also on the synthetic side, you have a lot of information, a lot of knowledge. Are we starting to see a blend, or are we starting to see crossover between those that have been in, call it a pain management regimen, that are either losing opportunity because of COVID, maybe not accessing their doctor, that are taking different paths to mitigate pain management. What are some of the things you're seeing in practice?
So a concern that prescription opioid use would lead to an opioid use disorder that would then be the street opioids or heroin. That's always been the idea that 80% of opioid use disorders started with prescription opioids has been floating around there. There's a couple things is right now we're having a shift in the prescribing of prescription of opioid pain relievers. So that's decreasing. So the ground's shifting right now. But as far as the relationship between prescription opioids and opioid disorder, that concern is still there, and I don't think that's going to go away because the use of opioid analgesics is endemic, and that's really, it can only be minimized so much without displacing those patients that are on prescription analgesics to other sources like non-medical sources like heroin. I'm not exactly sure what the relationship is because it's floating around right now. It's as the opioid supply changes and there's some other cultural changes. We might still be seeing a significant risk of individuals that are on prescription opioids, especially when those opioids are reduced or stopped, that they may go to non-medical sources like buying it on the street.
And we'll return in just a second, so I want to talk about some of the treatment modalities, especially buprenorphine, Suboxone, if you will. But we'll get to that in a second because as we're discussing the environment of opioids, and this is a great opportunity to talk to law enforcement with interdiction, are you seeing, well, let's ask, what are some of the trends you are seeing? Are we seeing an increase in trafficking, or are we seeing it within, again, those analogs being broken up in smaller distributions, et cetera? What are some changes you've seen over this last year?
This isn't over the last year, but to speak to what the doctor was talking about, when the state started restricting the availability of oxycodone as a whole, that's when we launched into this whole heroin epidemic, which has been a few years now. In the last 2 years, certainly during the pandemic, we saw a lot of what people thought was heroin usage, but unfortunately it was fentanyl, and we did have it tested at the lab, so we know what was in it, and some carfentanil. Now what we're seeing is almost just fentanyl, very little heroin, not a lot of carfentanil, but like Chief Campbell said, it's taken a lot of Narcan to revive the individuals that we're able to revive. We do have some good news last year during the pandemic. I think it was a perfect storm, a perfect terrible storm. Law enforcement, we had to take a backseat. We weren't doing traffic stops. We weren't doing search warrants on drug traffickers because we were trying to keep from spreading COVID around. We saw our overdose deaths spike almost immediately, and whether that was because of COVID, I'm sure that played a role, or because we weren't as hands-on, doesn't matter. We went right back to the drawing board and we started hitting it hard. Our deaths last year ended at 41 deaths in the county. Right now we've got 20 so far, which is a lot, but we're on track to be a lot better than we were last year. So we think pushing back on these drug traffickers has actually been very beneficial.
And we're seeing through CDC, Florida as a whole is trending up for the year. They're predicting a 35% increase over last year with a national trend of about 30%. So hearing Martin County is trending lower than that speaks a lot to the protective factors that we have in place. And Dr. Marshall, that's one of the most important things when we start talking about that idea of isolation and the backdrop of COVID. That does eliminate some protective factors for our individuals. And of course at Tyson Teens you see dozens and dozens and dozens of families and children and the effects of this. What are some areas that you're seeing changes year over year?
With COVID, certainly there's been more of a need, and unfortunately, our capabilities are stretched beyond what is capable. And I think that is said through the different agencies that do service children and families in our community. But a lot of the impact has been just heightened anxiety, more anxiety-related disorders, more family discourse, and things like that. It's kind of like the perfect storm for a lot of families.
Now, are you seeing any individuals, or certainly more in the adult probably than the teens, but an increase in substance use disorder as far as a primary diagnosis?
So it's interesting that you asked that, because here is my concern. We have a substance abuse program in the agency that traditionally has seen youth anywhere between the age of 10 to 18, and primarily it's been marijuana usage, because a lot of times that's what children can access most, marijuana or alcohol. But our census for that program has reduced, and what our belief is, the reason for that is that with the different laws that have come forth, a lot of our teenagers, as well as the parents of teenagers, are normalizing marijuana usage, so they are seeking out treatment a lot less, and not until it becomes a significant issue. So that's where my concern lies, where what is the next wave, what is the next epidemic when it comes to substances, with this being the case.
They're not seeking it for marijuana. I think, what was it, 2013 or so was the crossover when adolescent intake went from primarily alcohol to marijuana.
Right.
So, yeah, that'll be an interesting predictor. As far as you talked about behavioral need and stretching our resources to the max,
Yeah.
what is out there if people are seeking help?
Well, there's our organization, but again, we have some limitations with that. We have Helping People Succeed locally, Suncoast Mental Health, New Horizons, Catholic Charities, but I believe, again, we're all at probably at full capacity, and then being stretched even further, because we do want to continue helping. So, I don't want people to stop calling, but just to know we are at our brim.
And we'll touch on the school side of that as well in just a moment, but I want to check in with Robin, because with the community really kind of at its stretch point right now, it's also relied on as a key piece to support those in need, especially suffering from substance use disorder, a lot of behavioral health issues. It's falling to families, it's falling to community partners. And in this past year, you were part of a team that opened a recovery community center. It is in Delray, Martin County. Trust us, we're working on it, looking to work something out here too.
Yeah.
But, and could you tell us a little bit about that environment and how you're seeing it be supportive for those, especially those in need of basic services and connection?
Yeah. So, again, to kind of, echo what everybody else is saying, we, as somebody that was boots on the ground during the pandemic, a lot of that changed. We weren't able to be out there touching base with people, kind of reaching them where they are. So opening up the hub, the Recovery Community Center, has actually, even working within COVID-friendly restrictions, it's able to, offer a place where somebody is met where they're at, whether they're still in, active addiction, or as they're starting to transition into, actually trying to start working a program, seek treatment, doing those kind of things. But it's that piece that falls down so often. Somebody comes out of treatment, they're going into sober living, they're having to get a job, and, they don't know how to, start putting the rest of the pieces back together. They don't know how to seek health care. They don't know how to seek therapeutic services. They don't know how to manage legal. How do I begin this? I don't know how to get my ID. I don't know how to get food stamps or food assistance. I don't, so those are the pieces that we offer at the hub. It's peer driven, so somebody is offered a peer and that person continues to follow and, help them along in their recovery.
So you talk about this groundswell. It's a boots on the ground, community driven, but individually focused. The needs of the individual.
Yes, all individual. Yeah.
And this is an individualized disorder.
Yes, it
really
is.
Everyone is different. And I think not only those that are in the throes of either their current addiction or they're in the work of recovery, but I also think of our community and our professionals. I certainly think of our moms and our advocates out there and the time, effort, and energy they've put in. And I did want to reach out to Chris here and think of our public safety, and certainly we'll check in with Chief Budzig as well. But how is your team? How are they doing with this? This has been ongoing for years now.
Absolutely. It really kicked off bad in 2016, and we saw a tremendous increase in numbers. And since then, it's been a roller coaster for the most part, good years, bad years, good years, bad years. But if you combine that with all the stress and everything that's with COVID and the pandemic, there's a lot of people on edge and stressed out every day. Plenty of people using sick time just to get some time away from work. Overtime goes through the roof. It's a very big challenge for every single person out there. And I can't even imagine working in a hospital. So the first responders are definitely stretched thin and under constant pressure.
I wanted to share that with Jay, too. What are you seeing in Dr. Cuchero with you're in a private practice setting, but you spend time in hospitals. How is the environment for your profession as a whole so people can really understand?
It's horrible. I mean, they're just completely swamped with the COVID problems. So it's, and I can't help but think that it's going to detract from the care of individuals entering a hospital system with an opioid disorder. I mean, it's just completely overwhelmed with the COVID pandemic. So bad.
That follows certainly with what what people are reading, what people are seeing. But again, to hear that from folks on the ground that are seeing it every day, this is a human issue. This is a human crisis across all fronts. We had a question that came in via Facebook. I think it's a very important question, especially in the last couple of days, because there's been a lot of talk of it. There was a conference out of the White House regarding the opiate lawsuit and the opiate settlement from Purdue Pharma and others. And it has a question about, is there funding for local agencies to cover costs? I'll speak just quickly some information about that, but then we can maybe have a discussion on some of those solutions around some of these new resources coming in. I want to open that up a little bit first. But so people understand out in the community that this is a series of ongoing, or I should say the culmination of around the country, hundreds of lawsuits filed by states, municipalities, counties, individuals against the companies that produced oxycodone. And it's coming sort of to a head right now. I think one of the challenges that they're facing, so the first answer is they're funding for local government, and the answer is yes. This is how it's going to come down, and also some will come through the state. The county will have an allotment, as well as municipalities over a certain population. However, you start cutting up what seems to be a big pie a lot of different ways, and you actually wind up with a very small overall resource. Now, the benefit is it's long term. It's 14 to 18 years. The challenge is that it's not a significant amount of money. Some people ask, well, can it cover the cost of treatment? Well, right now, I believe Martin County is on tap for somewhere around $146,000 per annum. Now, that's no small chunk of change, but if you look at the cost of the work that all of you do up there, that evaporates in mere minutes. So for the community, being strategic with the assets that are there, now that is just a drop compared to the resources that the county provides. Martin County is a very robust county. It's a very generous county. So there's a lot of great services here. So I'd like to tune the question more to the panel of with the other resources. So, for example, we've had CARES Act dollars, we've had Rescue Act dollars, we've had other funding sources come in. Of course, with the fund budgets that you've had, are there areas that you're observing that's like, boy, if we could get enough resource here, we could really make a difference? What would you do with that magic wand, if you will, if we had that? And I'll start with Chief Budasing first.
Well, for starters, $146,000 for Martin County doesn't begin to cover the amount of lives and damage that overprescribing did for at least 14 years. I know they're supposed to be paying for 14 years. We have tried to really analyze this issue, and we're dealing constantly with mental illness and drug overdoses. And we can debate it all day and never come to a conclusion, but are they mentally ill because of drugs, or are they doing drugs because they're mentally ill? We're not sure. So we had already reached out to the county, and the commissions who normally sit here approved for us to have 2 new deputies to help us in the mental health field, so we can go out and try to really save these people from themselves. And a lot of these people are drug addicts. If we got more money, we would probably double down on that program, which that would only pay for 1 more deputy if you include all their benefits in their vehicle. But we would double down on that effort so we can go out, help these people that are mentally ill who are also using substances that are killing some of them.
And actually, I'll ask Dr. Marshall too, because of that correlation between mental health and substance use. Maybe you could speak a little bit about that as well. And as a citizen of Martin County, hearing of that program and understanding how those programs work, it falls right in line with law enforcement being a part of the solution, not to arrest the way out of the thing. It's how do we help? And that sentiment is throughout the county, and quite frankly, through a lot of law enforcement agencies across the state and the country. And that cohesive message is something that perhaps we can share better as a community as well. But Dr. Marshall, if you'd like to speak about that correlation between the two, and again, also, we know the backlog you have at Tykes and Teens. Let's talk about some, if we could procure, and if we could, what would you do with some further resources?
Well, I'll answer the first question first, and I think that that you had hit the nail on the head with regards to, is this substance because of mental illness or mental illness because of substance? And I think both things are happening, and it's very hard to differentiate, because then you also have the element of individuals that seek substance use because of trauma and things such as that. So it's very hard to differentiate, and I truly hope that our law enforcement does get the support, because I think it's 80% of your calls that end up being mental health related, I believe. I'm not quite sure what you would say.
You're very close.
Yeah. And that's unfortunate, and I think that also speaks to the low resources for adults that have mental health issues. We serve our children very well. We have a lot of great organizations, out there for that. But unfortunately, that's where where we have a lower availability. So for Tykes and Teens, it would be wonderful to have more great therapists. We, like to set the bar high, so the therapists that we have are the best trained. We do our own internal training as well. Unfortunately, our industry as a whole has a very it's been very hard for any of us to find more therapists out there. And that just speaks to how our industry has kind of blown up, because the need for mental health services is out there. So if I had a magic wand, I would wave it around, and hopefully 20 great therapists would come and want to work out there in our community.
I think that's one of the challenges. I'm glad you spoke to that. We have a shortage. There are not enough folks to fill these positions, and the need is growing. And that's across all these fields sitting right here. We're losing physicians, we're losing nurses, we're losing public safety, law enforcement. It's taking its toll. And so our greatest need, we're really rolling into a secondary crisis of service. And we'll be discussing that at the town hall later, I'm sure. But Robin, I wanted, as Dr. Marshall's talking about the need for adult mental health, and you and your team and the family you've created with our advocates and our moms and our parents that work with a lot of families and young people going through this struggle. are you, let's back it up a little bit, but when it comes to the mental health component, where are you seeing the most severe need in mental health? Because, again, 80% correlation rate somewhere. It's high. But when you're seeing folks literally coming out of program on the street, parents calling, what is some of that environment that you're seeing that's maybe changed this year?
So I think that, again, because of the pandemic, there's a lot of isolation that had been happening. People weren't able to get out. Of course, isolation for somebody that's suffering from substance use disorder is absolutely one of the worst things. One of the first things that we try to encourage them is to get out, engage in, with the sober community and with others, with peers, so that they can have that support. So again, are we talking, which comes first? We are seeing an increase in, mental health, depression, suicides, overdose people. I mean, I've had people call me many, many times over the last year just saying, I'm done. I just don't want to do this anymore. I've had family members calling, where can we get help? And then again, so then that brings us back to, there's not enough services out there. There aren't therapists. There are shortages. The need is increasing across the board, not even for people just that battle substance use, but, that are just, trying to live everyday life. So this is trying to, and Zoom for a lot of people, trying to do therapy via Zoom is just very hard for them to connect with somebody. They give up on that very easily if they can even get appointments. So it's really just trying to continue to support families, let them know that they're not out there alone, trying to connect, them with as many support systems as we can, so that they in turn can support their loved ones that are battling.
And as far as trainings or supports, and this is, if you think about it, families are the ultimate backstop of recovery and treatment. Mm-hmm. Are there any specific trainings, any specific elements that you would like to see in the community that could perhaps be supported?
Again, I mean, I'd like to say that, this has been going on. How long have we, been dealing with all of these issues, but I think educational programs for families, and kind of is still trying to teach families what this disease is about, including whether that's from the substance use end of it to understanding mental health. There's still so much stigma out there. There's still so much judgment, and it's just fear and people not understanding what these disease or disorder are. So if we could do something, I think that would be a huge plus across the board.
It's almost a top-down, bottom-up approach.
Yes. Mm-hmm.
And speaking of not only the mental health, but of course, being that the substance in particular we're discussing tonight does have a medical purpose, and I'm curious, Dr. Kuchera, as we are working through this in the medical space, what are some of the areas that are maybe promising? A physician we were talking to that we're familiar with said this is one of those crises that was medical-led, but for the first time medical-led, why aren't we looking for a medical way out? And we have such an incredible community of talented physicians, researchers. What are some things that are in the works or you've seen that may be looking at a medical solution to the opioid crisis?
So when I hear the term medical, I think of drugs, pharmacotherapies, because that's, we're not, so much in the behavioral care delivery setting. So, the mainstay would be buprenorphine, which is commonly known as Suboxone, but is available in many different other formulations. So I don't want to get stuck on the word Suboxone because that also is a bit vilified. And that still remains right now our primary pharmacotherapy. That naltrexone, although I have to say don't really have much experience with that, because in the pain world we have patients that are being treated with what we call the opioid. That's like the narcotic, like the oxycodone-related hydrocodone medications, and that's where buprenorphine fits in as part of that family. So in pain medicine, we're treating pain with buprenorphine as much as we can, and finding that theoretically and practically reduces risk of developing an addiction, what we call an opioid disorder. But as far as new treatments, biased ligand therapy, which is, a term for a pain medicine that produces pain relief, but then doesn't produce respiratory depression and death, or maybe associated with a lower incidence of addiction, which I'd like to use the word like an opioid disorder instead. But there's really, there's not a whole lot of really new stuff coming down the pike right now. We're still looking at buprenorphine as the mainstay, and to a lesser extent, methadone, which is only available through highly structured programs right now, and then naltrexone. And, one of the big problems right now is the continuing stigma and the malignment of buprenorphine by family members, by the general public, by the, court system, judicial. There's some judges on record as, looking at buprenorphine as just another addiction, so on and so forth. So it's very poorly misunderstood. And I think one of the ways to put it into perspective is, if you look at vaccination for COVID, there's a risk associated with that. But right now, the data very strongly supports benefit. And, if you look at buprenorphine, yes, there is risk. There is misuse. There is diversion. There are buprenorphine failures. But, there's abundant data. It's very robust at positive therapeutic effects with the use of buprenorphine. Now, I don't want to say that buprenorphine by no means is the only way to treat. And, the goal, I think, of an individual with opioid use disorder is to be completely abstinent. But, there's a substantial population out there that cannot do that easily. I mean, it's, the way I look at it is, if I asked you to stay awake I know you got a new kid, but if I asked you to stay awake for 5 days,
I'll say the sixth.
yeah, so, your brain probably would, pass out at 3 days. So asking somebody who's been exposed, their brain's been exposed to opioids for a long time, asking them to be abstinent from opioids and be functional, with a significant population of individuals, that causes a destabilization. And, it looks like buprenorphine right now is very helpful. But there's a lot more about that also, like duration of therapy and such. But it certainly is very useful. But, to answer your original question, I don't see anything really new happening. And as far as the treatment of pain is concerned, we look at things like using spinal cord stimulation, they call it, neuromodulation, or putting stimulators in, or different therapies, alternative therapies, acupuncture, and all kinds of, except there's some behavioral therapies. But whatever we have in other drugs, non-opioid medications, opioids certainly have a relevant place, and we're having difficulty treating chronic pain with injections and other interventions. Like I said, opioid therapy is probably endemic, and until we come up with a better solution, we're going to continue to use opioids. I just heard a comment about, overprescribing. The only, the main issue with using that term is that kind of perpetuates, that kind of leads the idea that if overprescribing caused such a problem that if we just don't prescribe, that things are going to be fine. But, that actually in itself has wound up creating an incredible problem. So, everybody's rushing to reduce opioid prescribing, and the consequences are not being fully recognized at legislative levels, at administrative levels, in healthcare systems, in offices, and amongst the healthcare culture. So, withdrawing or reducing or stopping opioid therapy is associated with increase in destabilization, mental health, all kinds of issues, suicide, poor functionality. It's really a very tricky place to be in right now.
And again, it's a long-term issue in that idea of other therapies for treatment, buprenorphine specifically. It is about time, and also combinations with other modalities, with behavioral health supports and cognitive behavioral therapies, etc. But there's this, and this is for Robin and Chief Campbell. One of the challenges we see in Florida is also the recidivism. I mean, this is an issue. People will go into recovery, get treatment, come out of recovery, relapse, and we're back. And are we seeing in our community, or in certainly calls, in your memory, are you seeing folks that are kind of in and out and sort of on that treadmill right now?
The treadmill's always there because the treatment has been the same for so long. If you look at the your typical rehab, that's all about abstinence. It's less than 10% success rate, and that's for people who want help and want to change their lives. I'm going to parrot him on the MAT. In my opinion, and from what I've seen in the last several years of really trying to find a way to address this issue, the only thing I've seen results, true, real, tangible results with thus far, is MAT, medication-assisted treatment, using buprenorphine. That went live in April of this year at Cleveland Clinic South. They started small to keep it small, and we approached it from a comprehensive perspective. Having a peer who's actually been there and had issues with those types of addiction in the past, coming to the hospital for somebody who has overdosed, and speaking to them directly about their options and their treatment options, making sure they understand that they had been there and it is possible. We had a peer, unfortunately, who just recently left us and moved, Lisa, who was a saint, and she was the best peer I've ever seen. She could talk people into looking to improve their lives and change their lives, and she was very successful with it. In the first month and a half, 2 months, April 20th through June 16th, I believe it was, they had 9 patients who chose to enter the program with MAT, and at 60 days, 7 of the 9 have not gone back and been readmitted. Just that alone, before that, 2 years of hard work, mind you, not even close to that level of success, and that was in the first 2 months. Since then, Cleveland Clinic North has gone live with it. And this comprehensive approach to this starts with the peer coming to the hospital. First of all, it starts with Cleveland Clinic allowing the program to be run out of their ERs and fully supporting it, which they have. And through a collection of the South Florida Mental Health Association, Houston, he helped tremendously get this started. I worked tirelessly. A lot of people worked tirelessly to make this work and get Cleveland to buy in. And once they did, everybody got educated. We started by approaching it with the peer program to talk people through the whole process. Then if one of the big problems is when they leave the ER, there's that dead time between leaving the hospital, having some serious opioid issues, and 3, 4, 5, 6 to 7 days later before they get their first appointment to follow up with the MAT medications. And that's where Martin County Fire Rescue came in to support them through those days with doses daily until they get those first appointments wherever we have a chance to get them. And then follow-up care through the Corey program and Human Services with Martin County Board of County Commissioners. It's a full comprehensive approach to this, and thus far, like I said, in just the first 45 days, it was 7 of 9, not a 60-day admissions, no 60-day readmissions of 7 of 9. And I know one of the other 2 that did have a readmission is back on the program and is past his 30-day mark at this point. So we're seeing success, and it is something that a lot of people put a lot of effort into to get to this point, and it's working.
And when you talk about fire rescue, is that your first? So the ER here is utilized almost as a receiving center for the opioid overdose, and they have the opportunity to join that program. So, for example, if you're out on a call, is Cleveland North or South your first? If that is the situation, is that where you take the patient?
Well, first of all, our people in the field, they're treating the patients like they normally would. If we revive them with Narcan or they admit to opioid use, we take them to the hospital. And at the hospital is where the ER physician and the nurses recognize the signs and symptoms of somebody who's overdosed, which is a pretty simple thing, especially when we bring them in, having revived them with Narcan. And from that point, they go through a whole process to see if they qualify with a COW score, which assesses how bad their withdrawal symptoms are. And if they qualify through their checklist, they contact the peer, who then begins the whole process to see if they'd sign up for it. And through the peer, the patient allows the treatment to take place, and then it goes forward from there. And if there is a gap between them being released from the hospital and treatment and or an appointment with New Horizons or what have you, that's where fire rescue fills in that gap currently until they do get that first appointment. So it's a process, and it starts with recognition in the field or somebody going to the hospital or ER. It's not necessarily receiving center. They're receiving center for those who have overdosed. And at that point, the treatment now we have a process to actually treat them versus sending them back out with tremendous withdrawal symptoms just so they can go try to find what they need again.
And you mentioned, too, that's for individuals or family members that need to bring their loved one to an ER. Because of that, it doesn't have to go through fire rescue, making the call first. They can just get there and
Absolutely. If you have somebody at overdose, number one, hope you have leave-at-home Narcan, and number two, get them to the ER as quickly as you can.
And actually, I do want to bring up the Narcan question. We get that a lot, especially today. There was, I don't know how many trainings around Narcan.
Yeah.
And we had discussions about Narcan this morning with one of our task forces and the need that to know that we need to have it. I did want to bring up to Jay real quick a question. People may have questions in the community about Narcan. Sometimes you see expiration dates on medications and such like that. Can you tell us a little bit about Narcan and its effectiveness, even if you have in your possession, if they have an expiration date, is it still viable?
Yeah, so Narcan, which is naloxone, it's just a brand name for naloxone, and I bring that up because an individual may have naloxone. They may have a different form, so it's all the same thing, so you can use it interchangeably. Yeah, there's good data that shows that Narcan naloxone is good for 5 years if it's stored properly. I mean, you can't leave it in your car, day in and day out, and have it exposed to thermal extremes, heat. But and I don't even know, if for the folks listening, naloxone reverses the effect of the opioid in the brain and is very useful. But you're hearing that it's not as effective with the synthetic opioids. The fentanyl family, carfentanil, and there's probably between 10 and 20 different fentanyl analogs, and there's also isotretinoin, and there's a bunch of several other synthetics out there that naloxone won't work that well, but still, it's good to have.
And so people understand, if you administer it and someone is not having a overdose situation, it won't cause them any harm.
Correct. Yeah, that's right. So I would give it to anybody that you can't wake up, or if you had naloxone and you saw an individual lying on the ground and they were not responsive. I mean, of course, the usual CPR is very important, but if they have a pulse or and even if they're breathing but they're not responsive, I would spray them, spray it up the nose. That's basically where we're down to that one formulation, because the intramuscular auto-injector is no longer on the market. So I would give it to anybody that is not responsive, because the chance that you can cause a problem is very low. And also, there's Florida statute that protects individuals that carry and administer Narcan.
And that's also reporting overdose. Our Good Samaritan laws are there, so you can report and don't, so people get the help they need immediately, again, from, the professionals that do it the best here in the community. And with those systems in place, as we're actually approaching, hard to believe, we only have a few minutes left, but as we're approaching, it's the idea for the community. We're in a rough situation, but again, being creative and working together, finding these solutions. And I just wanted it for the community. Narcan's readily available. Of course, fire rescue, it's part of your kit. I'm just curious, does law enforcement carry it or have access to in Martin County?
Yes, we carry it and we use it regularly. We've used it 50-something times this year already. We use it a lot. Now, to the doctor's point and the chief's, it's not, we only carry 2 doses per deputy. And it was waking almost everybody up, but 2 doses has not quite been doing it lately, just because of the analogs of drugs they're using. So fire rescue really are the ones that when they get there and really hook them up, that they're bringing them back around.
And I know certainly in our community, I was at the hub today, and you can get it readily in the community now. I mean, if you go back 3, 4, 5 years ago, if you said naloxone, most people look at you sideways. What are you talking about? And now you can get it. There was a tray of it. Please take it. Take a training. So for those in the community, please, it should be carried regularly. It's readily available with the cost. I'm sure that the cost burden to our public safety has been tremendous with Narcan. I think that's one of the consequences of this. But regardless, it's life-saving and life-changing. And for those in the public, please reach out to your public health officials, also your grassroots efforts, and check in with your moms. You can get Narcan and carry it and have it with you. But like Dr. Kuchera was saying, of course, you want to keep it in your glove box, but maybe take it out at least a couple times in the South Florida sun.
Can I say something about that?
Please.
We do have a Leave Behind No Narcan program within Martin County Board of County Commissioners and Fire Rescue. They can contact my office. They can contact Health Services. And through us, we will get you Narcan and the training that you need. And they can also purchase it at local pharmacies, no questions asked.
I believe it's a standing prescription from the state that anybody can purchase Narcan.
Absolutely.
Absolutely. So access here, except I was hearing, like everything with supply chain challenges right now across, that even naloxone was starting to have some difficulty getting to where it needs to go. So we'll keep our eyes on that. Hopefully that's not a trend that will continue. But that's a very, very important piece of this. So we've talked about some of the, on the ground, the solutions that are happening, some of the medical components, but let's start talking about how our community can engage. And I think this is one of those issues where Robin's talked about, actually everybody's talked about that. Everybody keeps talking about stigma and those challenges. Have you, with all this work and with, unfortunately, the pervasiveness of the issue, are you starting to see a different level of understanding within the community when you engage with them? How is that sea change happening in our community? I'll start with Dr. Marshall.
Well, it definitely saddens me about the stigma behind medication-assisted treatment, because what the general public doesn't understand, and I think there's still an issue with understanding that the doctor can probably speak to, that, this drug changes the brain. That's ultimately, what happens. And the treatment, even from the behavioral health perspective, has changed, where it's no longer abstinence only, and we're trying to get them completely sober, and you're not, successful until you're completely sober. We're just trying to keep people alive with reducing harm, like harm management, right, at the behavioral health level. So I just hope that people would educate themselves and understand that, this drug has allowed us to learn different things about addiction, different things about, how the brain works, and how we have to do things differently in order to treat, and that it can't just be, this pathway, and this is the only pathway. So I commend the doctor for what he's doing, and with programs like the peer workers that go out, because ultimately the individuals that are suffering aren't going to necessarily call up their therapist and make an appointment. It's truly the work of these individuals, these peer helpers that are changing what's happening. So I wish we had more in the community, like Miss Lisa.
That idea of the peer-led approach,
Mm-hmm.
experiential approach, is something, and also blending the two. behavioral support specialists, therapists riding along with law enforcement builds that, and I don't want to use the word barrier, I'm going to say bridge between law enforcement and the individual, where something may have turned out that wouldn't help the individual, but also keeps the law enforcement official safe. That sometimes isn't the best outcome, but having someone in between. Are you seeing a difference with family members being able to engage with law enforcement or be more comfortable calling law enforcement, knowing that that approach is different here?
We are hoping so. You alluded to the law that prevents an individual that's overdosing or their family or whoever called 911 from getting arrested if we come and render aid. And I think that's important for the public to know. If your family member or your loved one or boyfriend, girl, whoever's overdosing, call 911. We cannot legally arrest you. And I know law enforcement, we have the reputation when the cops show up, somebody goes to jail. That's our job, is public safety. Our job is to save them from themselves at the time. So we were having them kicked out on Cleveland Clinic steps, overdose, they're reviving them. We're hoping that the message is out there. If you have an issue, call the sheriff's office or fire rescue. We're coming to help you. Yes, we're still going to go after drug traffickers. Shame on them. Those are the big guys. We try to put them away. But also, one thing that's not been represented here is the state attorney's office. The system is now set up. We've come a long way in the last 20 years. Yeah, nobody wants to talk about the war on drugs, but when people do get arrested and they're a user, they're moved right into drug court, or they're moving into a program, or we try to move them in a program that actually gets them help. It doesn't just incarcerate them, and we've seen that that's not helping them. Incarceration's not helping them.
And I think you bring up a very good point too, and we just have only so much room on the panel, but the state's attorney's office across the state of Florida, certainly in District 15 and 19, have really been leaders, not only in Florida, but now recognized around the country as part of the solution to this issue. Again, finding different ways, utilizing drug courts. The next conversation is mental health courts, and using the legal system as an aid along with law enforcement to create opportunities for individuals. Crimes are crimes. People need to be safe. There's no question about that. But recognizing that, boy, there's a whole lot going on here, and seeing the value in the individual first, you're seeing some of that change, and that's commendable. And people sometimes don't see that. That's a lot of behind the scenes, and it's kind of dry, but it's a lot of change that has happened, and that also goes for the treatment as well. I mean, we've had success in South Florida trying to eliminate as many of the bad actors as possible. It's a very difficult thing, much like drug interdiction. You can do an incredible job, someone finds a way to get around it, but people are on it. And I think people need to understand that and get engaged in that process as well. And most of these forums are public, and you can share that information. So it is. I'm glad you brought that up, because that is a very important part of this that has changed tremendously in the last 20 years. And there's more to go, and they're still being creative and finding new solutions to that as well.
Absolutely.
Robin, on the community side too, again, that idea of stigma and how families feel about it and how it's changed. Are you finally seeing some movement as far as a better understanding at the grassroots community level?
I think that we're starting to see some change. So again, as we're starting to talk about using mat therapy and that kind of thing, it is about saving lives, because we have people. I've been in this arena for 18 years, so I've seen a lot of changes, and I get a lot of calls from the same people over and over and over again, just repeating that cycle, and taking Suboxone, using methadone or something like that is saving their life, and that's what it comes down to. And I think that families are starting to understand that it's just not another something that they're grabbing onto. I see within their own community, the recovery community, people are starting to accept that as well, because again, it's their own peers that are judging now, because now you're taking Suboxone, so you're not clean and sober. I think some of that we're starting to see changes. I'm hearing that from people that I advocate from over and over, and also sober homes accepting people that are on mat therapy, and also handling that in an appropriate manner, because a lot of times that's where we would start having some issues, because they are, again, they need to be responsible to take their own meds. But if you're in, that isn't always the case. Sometimes they're abusing it and doing all these things. So the sober homes are trying to work very hard with these individuals to take those medications appropriately and kind of monitor that. So we're starting to make a little bit of headway. We certainly have a long way to go, but I think that the more that we educate everybody, we're just going to keep growing. Mm-hmm.
And Dr. Cuchero, when talking about treating families and individuals, are you seeing, or I say are you seeing change, but are you seeing a difference in the client base or the patient base and their willingness to try different modalities, especially coming in with an opiate disorder and looking at, shall we move to harm reduction? Are we seeing that shift of folks seeking that as a viable and useful change in their lives and bridge, hopefully, to longer term recovery versus sort of maintenance on an opioid for the duration? So that idea of what people are accessing, what they're asking for.
Yeah, so my main view of the treatment of opioid disorder is in patients with pain being treated. So that's like a different population. And those individuals are challenging because they don't really regard themselves as having an opioid addiction per se, but that's just, they're using the medicine to treat legitimate severe pain. As far as families go, and I get a view of the families through being involved in the community recovery outlets and whatnot, the families still, we're up against a lot because there's a lot of bitterness when an individual is struggling with an opioid disorder, an opioid addiction, continually violates family trust, abandons the kids, sells, grandma's jewelry and steals everything, robs them blind, and overdoses again and again, and just they don't understand. So, from the lay community perspective, it's tough going, and I think one of the important things to do is to approach the community perspective on opioid disorder as a disease, as a brain disease, just like, like schizophrenia or maybe like a disease like diabetes or something, is to work at the different organized community levels like law enforcement, the judicial, the criminal justice system, conversations I've had with the state attorney to help them understand the role of buprenorphine and the idea of, brain disease. And I think that will translate, that will percolate down, and also mainstream media, if we can get them to give more coverage to the idea of opioid disorder as being more of a condition. But when it hits families so hard and it fractures them and it causes such incredible loss, the bitterness is there, and it's just really hard because the impact is so severe and it's tough. But I think we can continue to send a message. These forums are, I think, very important. Use forums like this to keep getting this outreach out to individuals that are suffering and getting families engaged in their own form of recovery, Al-Anon or just one-on-one therapies or anything that might help them just focus more on healing themselves. And what I'm talking about is the individuals who are related in some way to an individual who has an addiction. That's going to be really very important, I think. But it's a bad disease, and it definitely will destroy an individual's ability to act with conscience and control themselves, and that's clearly established, the effect on brain and executive function and just the overriding. It's tough, but I don't know if I'm seeing that much movement right now, but there definitely is. I see some really amazing stuff at the level of law enforcement, EMS. The criminal justice system is really coming around in a big way to really get behind the therapeutic idea here and the disease model, and to really pitch in and make a difference. So that's been very encouraging.
And I think that that's a great word to end on, encouraging and encouragement. Hard to believe that we've spent an hour in this conversation, and especially with the folks on this panel, we could stretch this into so many different areas with the expertise and passion that you all have. My message to the community, as I introduce them one more time, is to understand, especially on this day when we formally think about those we've lost in their battles with opioid addiction, and those that are still in that battle and those that are recovering, that we're here to care. This is a community, this is a county that is looking for solutions, that is finding different ways to do this work in a more effective and caring way, and seeing the individual as the value part of this equation. I can't thank you all enough for this conversation. I hope the community understands that this is difficult, it is complex, but there are people working every single day against the backdrop of COVID, still doing this work. So, again, I want to thank Chief Budensink. I want to thank Dr. Marshall, Dr. Neshka Marshall. I want to thank Robin Tupper. I want to thank Chief Chris Kemmel, and certainly Dr. Jay Kuchera for joining us this evening. Importantly, I want to thank everybody out in the community that chose to join us live here in person and also out in Facebook Live. Please, if you have other questions, reach out to our community leaders, from our commission all the way down to our public servants and to those that are boots on the ground doing this work as advocates every day. The community is here to help, and we hope that you reach out, seek that, and know that you're not alone. Thank you so very much.